All right, how's everyone doing? You know, we just came back from lunch. We're all sleepy, so I got about 100 slides to get through it, no problem. I'm just kidding. All right, so you guys know my name's Scott. Been a medic here for about 3 years now. So I'm going to be talking about kind of hospital destination, where we're going, who we should be bringing to what hospital. Go from there, and then afterwards we'll play a little bit of game, get a little interactive. Let's go on after lunch. So, what we're going to be talking about. So why is it important to take patients to the appropriate facility, the hospitals we transport to, and what the capabilities are. So why is it important? First and foremost, right, we have the duty to serve our citizens in the city. We're here to help to the citizens. We get called out to all their problems, whether it's a smoke check, it's I fell and can't get up, whatever it is. Our duty is to go out there and help these people. We're here to give the best quality patient care, and I truly believe that Rio Rancho provides some of the best EMS care within the state, if not most of the country. So our job is to provide that care, right? That care that we promise, that we showcase on all our apparatuses, right? Protecting your family. Also prevents the delay of care. If we have a patient that we bring to an inappropriate facility, all we are doing at that point is delaying their definitive care. We have a heart attack and we go to Loveless West Side. Are they able to perform those treatments that are going to help that? No, right? That's why we have to be going to the appropriate facility, because then they have to fill out a transfer, and then we have to go through that whole process, and that just delays the inevitable. And I think a lot of you would agree, most importantly, it adds more transports to us. So Rescue 10, who will have to go to Rust, and Rescue 2, who goes to Sandoval Regional. The more patients we bring to inappropriate facilities, such as Sandoval Regional or Rust, are going to have to get transferred out to get to that definitive care. So by going to the right facility the first time, we eliminate some of those calls from Rescue 2 and Rescue 10, already very busy districts. So what we're going to basically go through is just the different hospitals, and we're going to talk about what they're capable of, who we should bring them in. So UNM, kind of self-explanatory, right? They are our core facility. They pretty much, anything and everything can go to UNM. So level 1 trauma center. TICU, so that's a trauma ICU, and then the MICU, so the medical ICU. They're two different floors. They're a neurologic center, cardiac center, behavioral health, pediatric, NICU, PICU, and OBGYN. So they pretty much are everything. Burns will take them, everything you can think of. So with that, who should go? So Dr. Brody just talked about LVOs. Who remembers what those are? Large vessel occlusions. And what is the treatment for that ultimately? Thrombectomy. So they have to go in and surgically pull out that clot. UNM right now is the only facility who can do that procedure. So any suspected LVO, we got to go to UNM. Whether they're a breast patient, Loveless patient, anything like that, this is the only facility for that. Also, hemorrhagic strokes. Dr. Brody kind of touched on the hemorrhagic strokes that need to go to UNMH as well. All major traumas, so high mechanism vehicle accidents. This could be like rollovers of vehicles going really more than 40 miles per hour have a potential for high mechanism, the intrusion to the occupant space, ejections, stuff like that. Major burns, electrocutions, stabbings, gunshot wounds, all those need to go to UNMH because UNMH has that trauma surgery. STEMIs, or suspected cardiogenic shock. UNM has a cath lab and cardiac surgery capabilities, so they can not only perform angioplasties with caths, but they can also perform defibrillations where they put in those, or they can put in pacemakers as well. Active labor or post-delivery in which a NICU is required. So they have an OB unit, which we can bring in active deliveries. And then if we suspect a patient that once they deliver, that baby's going to need a NICU or some form of higher help, we can go there because they have a pediatric center as well as a very capable NICU. So this would be like a premature baby. If we have patients who were addicted to other substances, meth, cocaine, alcohol, whatever it is, and now we have those effects translated to the baby, those are all good indications of needing a NICU. Pediatrics, as we know, the UNM has that pediatric ER, so any trauma or medical, we can justify going to the pediatric ER. Other hospitals, as we go through, we'll talk, and we'll can handle pediatrics, but ultimately, if it's a very sick pediatric, UNM is probably the place that we should be going. But we'll talk a little bit more in depth on that. And then hazmat patients after decontamination. So if we have a major, which fortunately in Rio Rancho we don't have a ton of hazmat issues, but if we were to have one, first and foremost we need to decontaminate them, but then we'd probably be going immediately on that one. And then I want to look at our major trauma protocol. So we have a protocol in place, and it's kind of helped differentiate the difference of when we should go to UNM and when we should go to Sandoval Regional. Does anyone know what level Sandoval Regional is? Level 2. So UNM is level 1, Sandoval is level 2. So they can handle some trauma, but not to the extent that UNMH can. So just kind of going through this. First one, physiologic criteria. So this is going to be going to UNMH if any of the following. So GCS scale is less than or equal to 13. And this would be like after a trauma. Right? So we could have GCS less than 13 due to a medical cause. That doesn't mean we have to go to UNM. But this is like a trauma, now the GCS is affected. Systolic blood pressure, less than 90. Breathing, less than 10 times a minute or greater than 29 times a minute. And then changes a little bit with a 1-year-old. So less than 20 times a minute, probably consider UNM. And then it requires assisted ventilation. So this would be like we have them on the BVM or on the vent. We should go to UNM. Anatomic criteria. So again, this is all going to UNM. Need penetrating trauma. So this could be to the head, neck, torso. So these are our gunshot wounds, our stabbings. If we had a car wreck and a piece of metal or something went into them. Any penetrating trauma, we need to go to UNM on that. Chest wall instability, so this could be hitting the steering wheel, now we have some sort of flail chest. 2 or more proximal long bone fractures, so if someone fell from a ladder, landing on the ground, now we have a bilateral femur fracture or bilateral tib fibs. Again, consider UNM, or not consider transport to UNM instead of going to Sandoval Regional. Amputations, crush injuries, pelvic fractures, depressed skull fractures, right? All of these, as you look, like, it's pretty bad trauma. Yeah, so UNM. Now, stuff that we can consider SRMC are falls less than 20 feet. So anything greater than 20 feet, UNM, less than 20 feet, which more times than not, a fall less than 20 feet is more common. This would be someone getting on a ladder, fixing something on their roof. They slip, fall, something like that. Or in Rio Rancho, where we have a lot of old people. So they fall a lot, and that's always less than 20 feet. So if we have car wrecks, there's intrusion, including, and when we see intrusion, we can look at car wrecks and say, oh, that car is messed up. But when we talk about intrusion, we're talking about that occupant space. That's designed to not have any damage on the inside. So if I say intrusion, that means that now there are parts of that car getting pushed into that occupant space, affecting all the occupants. So anything less than 12 inches, but if it's greater than 18, that's a lot more mechanism we need to consider UNM. But less than 12, we can consider Sandoval. Just since we consider Sandoval and go, doesn't mean they still won't divert us, but it's something that we can consider going to, especially out in our far reaching districts. So like Station 2, you're out there pretty far, and you can get out there pretty far into the Sandoval County. Sandoval Regional might be a better option. What else does Sandoval Regional have that could facilitate another transfer?
Helicopter.
What was it?
Flight.
Yeah, they have a helipad. Partial ejections or complete, again, something we can consider Sandoval Regional. More than likely, though, we're going to get sent to UNMH anyways. Death in the same compartment. Why is that important?
Mechanism why.
Yeah, if I'm in a car with somebody else and my passenger died, what happened to me? Even though I might present fine, I went through the same mechanism that this person went through. There's a chance that maybe just those symptoms haven't appeared yet. Auto versus pedestrian, yeah, anytime someone gets hit by a car, it can be pretty significant. But it needs to be less than 20 miles per hour impact. So anything greater than that, and it's always hard to tell because anytime you ask, like, well, how fast do you think you're going? They always tell you the speed limit of 500. No one actually tells you how fast they're going. So I usually get whatever they tell me and then I add 10 to it. It's just kind of a rule of thumb that I like to do. Because I mean, let's be real, who in here actually drives the speed limit? all of us, because we have to. Motorcycle crashes, yeah. So other considerations, so older adults. Why older adults? What physiological changes do they have compared to younger adults? Yeah, they don't compensate as well. So if we're having potential shock, then we're having potential shock, they probably won't compensate as long. Why else?
The brain shrinks a little bit, so it can actually rattle in the skull.
Exactly. We're really worried about subdural hematomas, and that's why anytime we go on a fall, we say, did you hit your head? Did you lose consciousness? Are you on any blood thinners? Because of that higher risk. What else? What about their bones? They're brittle. Yeah, osteoporosis is a lot higher. So even though, if I'm with an older adult and I go through the same mechanism, I might not be hurt at all. But because of their physiological changes due to age, they might have a lot more significant injuries than I would. Anticoagulants or bleeding disorders, again, we kind of talked on that. Anytime someone has an anticoagulant or a bleeding disorder, what would be like a bleeding disorder? Hemophilia, yeah. They're going to bleed more. So that's the whole purpose, right? Anticoagulants is so like they don't clot. So it'd be like people at risk of PEs or AFib. And then bleeding disorders could be a genetic thing that we definitely have people in intervention with that. Any trauma to that is going to cause significantly more bleeding. Pregnant patients, greater than 20 weeks gestation. Why should we consider UNM with those?
NICU?
What's that?
Is it NICU at UNM?
Yeah, NICU. So if we have a pregnant patient, greater than 20 weeks gestation, who gets into a car wreck, now complaining of that severe abdominal pain, what is a worry that we have?
Miscarriage, internal bleeding.
Internal bleeding from what? Yeah, placental rupture. So that is going to need a PICU, NICU, surgical team. Something that all the hospitals in our area can't handle. So there's something to look at and consider. Most of the times we do a really good job of trauma. We can understand what the trauma is, what the mechanism is, and we usually go to the right facility. But remember that SRMC is that level 2, and it's somewhere that we can consider. We just need to make sure that we're not bringing anything outside of their control. Because if we bring them to SRMC and they can't deal with it, they might be able to initialize and stabilize it, but then we're going to end up transporting. That gunshot wound that happened, and the guy shot his wife, drove to SRMC, they stabilized there, and then what ended up happening? One of our crews took her all the way downtown. So it's something that we see and happens. So Sentinel Regional can stabilize, but ultimately they're going to get transferred out again. And most of the time, when a critical transport like that falls onto us. Same with rust. They're not going to wait for critical care. It's going to come to us. So if we can, I hate to say like we should go downtown more than we do, but there are times when we only go to rust because it's closer, it's quicker. We need to start considering, okay, maybe this patient actually is going to be better off downtown. Does that make sense to everything? Perfect. So, go straight in then to Sentinel Regional. Like we said, they're a level 2 trauma center. They can deal with orthopedics. What's orthopedics? Bones. A lot of times it's older people falling, fracturing their hip. Sepsis, reactive airways, so this would be like asthma, anaphylaxis, those sort of things. They have some GI capabilities. Can be used for stabilization for trauma or cardiac arrest. So if we do have that trauma, let's say we're out in the county, we have that trauma, flight's not available to get out there, we can bring them to Sentinel Regional for stabilization. They carry blood products. They have ability to intubate, do other things like that, and then we can transfer them to UNM. Or we can go to the helipad and fly them out. So just since, yes?
Go ahead and finish. I was going to ask if you could just provide some insight on what you guys' crew responded to and how you went about it.
Sure. Yeah, just since though it's a trauma or a cardiac arrest doesn't mean that we have to bypass that facility and go all the way downtown. We can still use that as a stop. Rust is another really good option because they have the same capabilities. They have that helipad, they have blood, they have intubation with RSI, all that. So, but yeah. Go ahead.
Yeah, so we had that stabbing in the Bosque, and just the way the call progressed, there's a lot of ways it could have gone, but arriving, the lady had basically just coded and the police officer was doing CPR. So though it was trauma arrest, there was a lot of like split-second decisions, like we could work it here because if she dies in the rig, this is clearly a murder and then we're gonna be here all night. But it was, hey, that's the best thing for her. She needs to be out of the cold, in the rig. We got pulses back, and then MedCom and my paramedic, it was Chris Garcia, made the decision. I think this is the best choice is going to be to go to Sandoval Regional. John had forgotten for just a little bit that he was an engineer, and he medic brain turned on. It was beautiful to see.
I never thought I was an engineer.
I mean, he was.
Even he was amazed.
That
I mean,
never happened.
he did great. He got the blood tubing set up, so that was already set up, and they did use blood at Sandoval Regional. I believe she coded again at Regional, but they got pulses back again. They have the blood on board, and then the understanding was basically that my crew was going to stick around because we knew that she was going to end up going downtown, which is exactly what happened. They took her downtown with, I think Brent left, but Brent happened to be there doing his ride along, so he hopped on with my crew, and then she ended up dying at UNM. But yeah, having the blood on board for the transport downtown, having her stabilized, that was all something that MedCom and my paramedic felt were beneficial.
Yeah, no, definitely. I mean, those facilities could be a huge pit stop for us. Yeah.
Sorry. Hey, Cap, how long did your crew stay at Sandoval? I mean, how long did it take them to stabilize?
It seemed like they were there.
You were there, right?
Oh yeah, he was
Yeah.
there
It
too.
was like an hour 30.
Hour and a half.
Yeah.
It was a minute.
When you made that radio call, did you ask for stabilization assistance, knowing that they were going to have to go?
I didn't hear the radio call.
I don't know. But they seemed, no one at Sandoval Regional seemed bugged that we were there. I would say, just judging by people's tone and kind of how they handled everything, no one seemed bothered that we showed up there.
That's for sure.
I've had a patient where we picked him up, put him on the 12 lead, very clearly having a STEMI. Said, okay, what system do you use? I use the UNM. Okay, we're gonna bypass Sandoval Regional and go straight downtown. En route, he codes right on the gurney. And I said, forget you downtown, we're going to Sandoval Regional. Because now it's a decision of, are we gonna work this code 30 minutes all the way to UNM? Or can we go to a facility that might be able to do other interventions to maybe stabilize this guy? Take him to Sandoval Regional, they end up getting him back, and then transporting him downtown to the cath lab. It makes a full recovery. Okay, so things like that can be huge for us. Do we always have to go inside the ER though? No, because what can we do? We can call a helicopter, PHI, lifeguard, say, we're gonna meet you on the helipad. Instead of you flying to my scene, I'm gonna come straight to you. And I think on B shift, they've done that a couple times. There was a self-inflicted gunshot wound. Got him on scene, there was nowhere for that helicopter to land. They were 5 minutes from Rust, drove to Rust, loaded straight onto the helicopter, and never even set foot in the ER. So those are all options too. That's why coordinate with dispatch, see who's available and what's going on. Giving an early heads up, so if we are bringing a trauma like that crew had, Sandoval, give them an early heads up because they now need to get ready. They're not normally ready for a trauma like that to come in. You give them an early enough heads up, they can get ready for you. Just like at UNM, we give them a heads up, trauma alert, we walk in and everyone's all fully gowned up, ready to go. That's why those alerts are important.
So if you're going to like SRMC for stabilization, how should you word that in your report to the hospital?
You tell them what you have. So if it was a multi-system trauma, you say we're coming at you with multi-system trauma for stabilization.
Yes, sir.
Tell them what you have, what you've done, what their vitals are. If you had a cardiac arrest, you say we're coming with a cardiac arrest coded en route to the facility. Go from there.
Yes, sir.
All right, so talking about what we can bring, what should we not? So I mentioned major trauma, unless for initial stabilization. Cardiac arrest, again, unless for stabilization. Do we really transport cardiac arrest if we show up on scene and they're in cardiac arrest? Do we load them up and go?
No.
So what's really the one exception that we do that with? Well, ROSC, but the only time we really transport a cardiac arrest. ECMO criteria, yeah. So, and that's to Rust. So, wouldn't really worry about that. Now, if a cardiac arrest occurs inside our rescue, now we have a little bit more means of transport. So we load them up, they code. Okay, well, they're already in it, let's just go. You can work it on scene, but if you work it on scene and call it, then what do you have? Crime scene. So OMI has to come out, they have to do their investigation, and now that rescue's out of service. So if they're in your rescue and they code, just go to the hospital.
Was that consistent with what Dr. Brody's mentioned in the past? I know in the past he has said pull over and call for either RIO units, AAS.
If you have the hands. So if I'm in the back as a single provider and they go into cardiac arrest, I would say pull over and get more hands. Because at that point, all I am able to do is compressions.
Right.
I can't put them on the AED, I can't do an airway, nothing like that, because I'm a single provider in the back. If they code with your whole crew there, then, okay, you, get in my rescue. Now we have enough people to perform cardiac arrest. I can do airway, I can do compressions,
While
I
you're
can do all
involved
that.
in the hospital.
Yeah, so I think it depends on what resources you have. And it's all provider judgment. If you have a provider that says, I'm more comfortable not moving and just working it right here, then that's fine. But if you have the resources and feel comfortable transporting, then just transport at that point. So other things, strokes, unless it's been greater than 24 hours. So after 24 hours, we're kind of out of that range of any of the treatments that we can perform. So any facility can receive those types of patients. However, less than 24 hours, and we're suspecting like an LVO, unit downtown. Or if it's less than 24 hours, not suspecting an LVO, we can consider rust, especially in our area. Rust is probably the best stroke area, or the stroke facility, unless it's an LVO. STEMIs or cardiogenic shock, they don't have a cath lab. Pediatrics that may require hospitalization or PICU. So who here in here has brought a pediatric to San Juan Regional before? I have. Yeah, so we can still do it. They'll still accept pediatrics. However, if we're thinking that, okay, this kid's pretty sick, he's probably going to need to be hospitalized, San Juan Regional might not be the best option. Where they can do hospitalization, they don't do hospitalization of pediatrics. And then OB, they don't have an OB facility there. So any OB, we need to consider going to downtown. Moving on to the Presbyterian systems. So they have neurologic, so with the exception of LVO thrombectomy. And in reality, where are we really going to be taking any stroke that's a press patient? To rust. It doesn't really make sense to bypass rust. Rust is a 24/7 stroke center. Hemorrhagic strokes, however, they do have some capabilities of that, but as Dr. Brody says, a lot of them are still going to be transferred to UNM. So if you do have a suspicion of a hemorrhagic stroke, which it's pretty difficult to identify in the field, a lot of times we can identify stroke-like symptoms. Can we determine between an ischemic or hemorrhagic? It's a lot harder. That's why the first thing that they do is do a CT scan. Okay, what kind of stroke is this? They have cardiac catheterization with cardiac surgical capabilities. So why would we bypass rust if rust is a 24/7 cath lab to go downtown? What would be the reasoning for that?
Post-care.
What's that?
Maybe Rust already has somebody on the table.
That's a good one. Maybe Rust already has somebody. They only have one table. So if they're already doing procedure and we call in a stroke stimular, they may say, take them downtown. We don't have enough people to perform another one. What's another one? I think I heard someone else say something.
Post-surgical care.
Post-surgical care? Yeah, that would be another option. They can have a just recently implanted pacemaker or defibrillator, or open heart surgery, a cabbage, whatever it is. Probably need to go to downtown because of their cardiac capabilities. Rust, and I'll talk about this in a second, they have a cath lab, but they don't have any cardiac surgical. So if I have a patient that I'm suspecting a cardiogenic shock, we identified a STEMI, but now we're thinking, okay, maybe this person's in cardiogenic shock, we need to probably go downtown. Because downtown can perform the defibrillators and the internal pacemakers, which ultimately that person is going to need. They have the ICU, they have OBGYN, PICU, NICU, and GI surgical capabilities. So if we have a pediatric that uses a press facility, and we think that they're going to have to be hospitalized, we go to the pediatric ICU, bypass rust, and we're going to go downtown. So again, we kind of already reiterate that. We already talked about it.
Talk about stroke.
Oh no!
So Rust is a 24/7 cath lab, but doesn't have any of that cardiac surgical capabilities. They're also a stroke center, but that's for ischemic strokes. So strokes that we're suspecting a lasting normal of less than 4.5 hours, we can go to Rust. And that's really anywhere in Rio Rancho. So if they're a Loveless patient, Loveless West Side patient, and say they're having an active stroke less than 4.5 hours, that is where we can say, I understand that they're a Loveless patient, however, we have a stroke center closer than Loveless downtown. Could we go there instead? That saves on time, and there, the argument usually comes up of, well, my insurance. In an emergency setting, we're emergently transporting a patient to the hospital. Their insurance should cover it, regardless of what facility we go to. So just have that conversation with them, because ultimately, time is tissue. If we get them there quicker, a higher chance of good outcomes. There's GI capabilities. However, how many of us have done a GI transfer from the GI side of Rust over to VER? Probably all of us in here. It's kind of frustrating. However, they do have GI surgical capabilities. So if we do go to VER with a GI problem, a lot of times they can't handle it. They have an OB floor, but they don't have a NICU. So any complicated birth that we have, so a breech presentation, a prolapse cord, limb presentation, all those probably need to go downtown because that's going to be surgical. Yeah.
We did have a breach with a presenting limb. Actually, we picked up Dr. Brody a few years ago for it.
Mm-hmm.
And we ended up calling Rust, and because they were going to do C-section, they said we could just go straight there. So we did end up going to a Rust facility, so it may be a matter of calling early also for some specialty situations.
For sure, yeah, definitely call early. So my computer's restarting, so that's cool. So we'll continue on, but yeah, what's up?
We had a patient, I forget exactly how many weeks she was, but she was a known fentanyl addict, and she was suspecting that the baby was stillborn and that she was going into labor. We ended up taking her to Rust. Rust didn't give us any kickback. Would that have been the right facility, given her past history with the drug use and all the things that he was into?
So the issue with chronic drug use during pregnancy is all those drugs that the mother takes can diffuse through the placenta into the baby. So we get babies who are coming out essentially high and addicted to these drugs. Most of the time they're also premature, born in the 25 to 36 weeks. There's a lot of times when we see those babies born. In that case, they are going to need a NICU. If it's for a stabilization reason, then yes, Rust could be an option. But if, like, let's say we had active delivery on that and we did deliver that infant, not only are the chances high that we're going to be performing neonatal resuscitation, but at that point, we know we're going to need NICU at that point. So try to go downtown with them. If you go to the OB at Rust, they're going to schedule a transport. Maybe it might not be emergent, but they're going to schedule a transport and send them downtown anyways, whether that's AAS, AMR, or us who does it. I know they've been calling us recently for a lot of OB transfers because we're always available. Right? They call us, we show up. They always say, wow, you came super quick. Yeah, that's what happens. So just have that idea. There's probably going to be a transfer from this.
Did you have a medic with you?
No.
So that's another thing, right?
And-
Need a BLS bus versus.
Yeah, and then I think the biggest concern was, so she ended up not being in labor, but with her saying that I think the baby is dead, I didn't know. Rust, we were in 10's district and Rust was 5 minutes or less away. So that's given that and given her history, that's kind of why I made the decision to go there versus all the way downtown. And I haven't been on many OB calls, let alone one saying I'm going into delivery or going into labor and I think my baby's dead. So that's why I chose Russ in that situation.
Yeah, and I could stand up here and talk all day about, well, if you have this patient, you need to go to this facility. But how realistic is that?
Yeah.
It's not, because not every call is the same. Not every call follows a set of guidelines. So I can say, hey, if you have this patient, you should go to this hospital. That's not always the case, though. There are times when there's other circumstances going on. There's other things that happen. So if you go to a facility, ultimately you're going to a facility that can provide a higher level of care than what we can do in the field. And that's first and foremost the most important. Any facility we transport to has more capabilities than we currently have on the rescue. So you wouldn't be wrong. This is to get an idea or start considering of, okay, what facilities do we have at our disposal, and is it worth our time and worth the patient's time to actually go downtown? Could this be a quicker to definitive care? Could this prevent another transport out? Even if it's not preventing a transport from us, would it be preventing a transport from other agencies? Because Albuquerque Ambulance, they run a ton of calls and they're almost always level 0. If we can prevent a call from them too, that helps Albuquerque. Because again, we're all in this together. Maybe if we prevent AS from going on a call, they can take that transfer that they're supposed to take out of Rust instead of Rescue 10. So things to think about. These are all things to just consider.
It sounds like what you're talking about is being an advocate for your patient.
That's it. That's the one.
Use that word.
Hold on, just a sec. Technical difficulties.
Scared me.
Okay. Yep, so again, Rust, especially for your stations 1 and 10, they have that helipad. So we can rendezvous with them. If we can't get them to land out on our scene, let's go to them. We can still fly them out. Call them up, hey, we have this patient, we're about 10, 15 minutes away. Not only does that shorten their response time, because all they have to do now is their weather check, their confirmation with the crew, and they can start that helicopter running up. We pull into the bay, load them up, they can fly straight to UNM. Lowe's West Side, so they have orthopedics, so falls, fractures, stuff like that, they can go and deal with. Non-critical patients, so we bring a lot of sick people here, but not those critical patients. A lot of times we are transferring people from like the Genesis or the Suites Rio Grande. A lot of them use the West Side system. Those are all good people to bring to. They don't have a cath lab though, and they're not a stroke center. So if they have one of those two, gotta either consider downtown or potentially another facility. Just since they use a Loveless system or a PRESS system doesn't mean we can consider other options. Like I know with the VA, whenever we hear VA, we're like, ugh, how about Rust, right? These are all options that we can still consider. Downtown, not a ton of reason to go downtown, to Loveless downtown. If we're going to a Loveless facility downtown, which one is it typically? It's Hart. If Hart doesn't accept us, then we usually get diverted to this one. So has anyone gone to Hart and then they say, yeah, just go downtown instead, divert? Yeah, that happens a lot because Hart is very particular about what they take. The only real reason why we would initially go downtown is potentially for a stroke center. And that would be after I would try to go to Rust first. Sometimes you get that one transfer out of a facility that they're like, they have to use downtown, the doctor's already accepted, this and that, then we're going downtown. But typically we don't go here a lot. Heart, Loveless Heart, we're gonna deal with heart issues. So STEMIs, cath lab capable, cardiac surgical capabilities, and what else do we take here that we just talked about? LVADs, yeah. So LVADs are gonna be what goes to heart. Women's, we don't typically go here a lot either, but OB and NICU capable. And then the VA. So,
will Loveless only accept, will Loveless Women's only accept Loveless patients?
I'm not actually sure. I think if they weren't a Loveless patient, we have other options to go to. So if they don't have insurance or they don't use one of the core facilities we have, Loveless Women's would not be my first option because of how far away it is. I could hit multiple other hospitals before we get to Loveless Women's. But. So the VA, who are we taking to the VA? I mean, really our goal is no one. But ultimately, if they want to use the VA, we got to bring vitally stable patients. We can bring minor orthopedic injuries. It's not a stroke or cath lab, and be cautious with falls on blood thinners. I'm going to say like 80% of the patients who go to the VA are on blood thinners, which is kind of how it goes. I've had it in the past where we're bringing a fall who hit their head and have blood thinners to the VA and they divert us. If it's, my philosophy, and every medic's going to be a little different, but if it is a truly sick patient, there is 5 other options I can go to before we even get to the VA. That would be more beneficial.
The VA has my records though.
VA has the records, but and VA patients are a lot of times very adamant on, I use the VA, I only go to the VA, I'm going to the VA.
Well, Dennis, what's that thing that you were talking?
Yeah, so I was actually talking to one of, she's actually a nurse at one of the facilities we go to, but she happened to be also a VA patient. And it was in I think 2014, I could do a little bit more research to have something like hard track, but it was called, I believe, the Freedom Act, that the VA got pushed through because there's a lot of lawsuits. And a VA patient can seek care at any ER, and the VA insurance has to cover it. So them having to go to the VA to get it covered is a fallacy anymore, especially with that act. She was telling me about it, and we're sure that they could go to any emergency room just like anybody else, and their insurance has to pay for it. Now, if they need further care, then they'll be transferred to the VA, just like any other patient that needs to be transferred to their facility. But a lot of people aren't aware of that.
Yeah, and that's a great point to bring up, and talk to your patients. Educate the patients. I understand you use the VA, all your records are here, and you're worried about insurance costs. Because most of the time when we hey, you want to go to the hospital? A lot of people say, what's it going to cost? Or it's too expensive to go. I get that. That's a totally real reason.
And a lot of people are pretty accepting too, the ones that I've told about that. Like, hey, your insurance will pay to go, down the road, and in that case, like, if they, release you, you're right next to home. You're not downtown. You don't have to arrange transport later.
That's usually the what I say. So I understand you use the VA. However, what's going on right now, we can get that same care level, if not greater care level, closer. Instead of going all the way down to the VA, I can get you help quicker. It's still going to get covered by your insurance, and most people are like, okay, yeah, let's do that. So the big takeaway of this is, again, it's not me coming over here saying we need to go downtown more. It's something we're thinking firefighters, we're thinking providers. Let's look at this patient we have and just saying, let's go to the hospital, Rust is right down the road. Okay, is that actually the appropriate facility? What other facilities might be better for this patient? So, just things to think about. Any questions on this part? Yes?
I was just thinking about the pelvic fractures. All those are going to go downtown to you now?
Yep. Because pelvic fractures, in order to have a pelvic fracture, you have a significant mechanism of injury to that body. Now, how much blood do you think we can lose through a pelvic fracture? Does anybody know?
1 to 2 liters.
1 to 2 liters, if not more. So breaking that pelvis, we could bleed out through that, or bleed out enough to go into severe shock. That's why we have that binder, is to seal up that pelvic fluid. But in order to fracture that, it's a pretty significant injury. Because when I say hip fractures, what am I actually fracturing? Am I fracturing my pelvis?
Femoral.
It's my femoral head or the neck. The kind of neck between the ball and the long bone of the femur. So that is what's fracturing. That is what we're considering the hip. So those we can go to pretty much any facility. Pelvis fracture,
When it comes to a transport from a facility, maybe like 4210, and maybe some of you Station 7 guys can speak to this, they have requested a transport to Caseman for whatever reason. Is that something that you guys have noticed who work at 7? Is that still?
Usually Russ is a more appropriate facility for.
Right, but do they still say like she needs to go to Caseman? Because
they could. I mean, yes, there's been a couple of times that they said that, but they're Presbyterian patients.
Yeah.
Caseman's a Presbyterian facility, so as long as there isn't like a strict order or something, then Rust is still going to be our destination of choice. And they can
that's what I'm saying. When there is a strict order, how do you guys navigate that? Is that something
base it
you
off
have
of
to deal
patient presentation at that point? If it's something so emergent that it's going to affect us, then obviously I usually in those situations would contact either Medcom or battalion chief and find out if we're cool, if it's good enough to take a 40-minute ride to Casement for a patient that is stable and whatever the case may be.
A lot of times those facilities as well will say, they have to go downtown because that's where their surgery was.
After hours,
It's like, no, they don't have to go downtown because that's where their surgery is. It's not like it's their surgeon and they're going to wait in their ER room like, all right, I'm here to help you. No, it's like,
But I
you're
guess
going to
that-
the ER at this point, so we can say, instead of going downtown, we can go to a closer
I
facility.
guess that's my question is on the back end, they've already made arrangements with the doctor at some facility, not understanding that that person could get the same level of care down the road. So when that order's already in, I mean, is it our place to essentially do the right thing?
I used to have a talk with the facility, and a lot of times they'll say, yeah, the doctor wants them sent out here, but they haven't actually really sent that order out. They'll say they sent the order out, but you say, hey, we have a closer facility. It's not within our protocol to transport outside of our jurisdiction, essentially, to go bypass another facility that can handle this. So we're going to actually go here, and then that's when they might step in and have more with that. But again, like Gertie said, talk to the Medcom, talk to the battalion. I don't know if Captain Ray has more to say on that.
Yeah, the other conversation that you might want to have with the patient is if it's something that we all are under the impression that is not suitable to be going downtown with, maybe some education with the patient is, hey, your insurance may not cover this if they don't deem this a necessity to go to this facility. And then we also have that conversation with family or POAs, because that's an issue that I've run into before as well, where the family is adamant that this patient needs to be transported to a court facility where it was a very non-complicated medical issue. So having that conversation with them is, hey, Medicare or Medicaid or your insurance may not cover this, and you may be responsible for whatever is not covered. And if that includes a bill in its entirety, then that's what it is. But that's one of the consequences or potential consequences that those individuals face.
I have a little bit of follow-on, I guess. Once the order is sent, like say they want them to go to Casement, just to use their example, cap cases, are we actually bound by that once the doctor makes arrangements or whatever with the other doctor? Are we bound? Not that we should fight it, but I'm just curious, like wise.
Yeah. I don't want to comment too much because I haven't been faced with that situation a ton of times. It's more often a recommendation or a preference. It's not something where it's actually a physical document saying this is where this patient needs to go. I'm the physician signing and requesting that this transfer be done to this facility. So I don't necessarily want to.
I think what I've run into the most, and I think kind of a similar situation, is that after our pediatrics at concert, every time we pull a pediatric out of there, they're like, oh, they want to go downtown. Or they'll say, we're sending them downtown for this. And a lot of times it's like, a fever or a little respiratory infection that they're probably not going to get admitted for, probably not PICU. And I'll ask too, well, are we going to the ER downtown? And they're like, yeah, but they have PICU capability down there. And so I'll ask the patient, hey, Russ is right here down the road. They have the same capability as far as ER. Like, again, if it's not something that's probably going to PICU. I have run into where they have, arrangements where they're going to a room upstairs on the floor, and in that case, it'll be like, okay, they already have the room, the doctor's already accepted, in that case, we'll just take them. But if it's like ER to ER and it doesn't look like something that's going to be admitted downtown, I always like to give the patient that option, and a lot of times they're like, yeah, the facility told me I had to go downtown, but if I can go to the ER here, let's do that.
And, just like anything else, I would be cautious in your approach because we obviously don't know everything. It depends on experience, your comfortability. Are you willing to justify that if something comes a bit later on down the road? That's, I think, ultimately where I look at it from and where everybody should look at it from as well. Is are you comfortable at the end of the day looking in the mirror and being okay with that decision that you made where there is definitely the potential, no matter how big or small, we hope it's small, but can you live with that if it happens, if there are repercussions that come out?
And there's times that we're going to have to just go downtown. We can say, is downtown the best place for us? Probably not. Russ can handle this.
Depends on how the shifts come.
Need a break?
But there's times then that's like, we're just going to have to go downtown. We're just going to have to eat that sandwich.
What do you mean we're going to go downtown? It's a stuffed toad. Yeah, but
I think that was the root of my question. More, is it worth or is it professional arguing with the doctor? When do you decide to die on that hill?
I think it depends on the situation, right? 4210. when crews would try to go there and say, okay, why are we sending this patient out? Or we shouldn't be sending this patient out. And then a whole thing blew up from that. And now they're like, our crews are attacking them and this and that. Obviously, bad situation. Try to have that conversation. If that conversation is clearly not going in our favor, and it almost never does, say, all right, fine, we'll take them downtown. It sucks. It puts a unit out of service for an extended period of time. We're going way out of the way. But it's almost better to just take them to the facility instead of having to deal with all the backlash of that, working with the facility in that matter. Because then every time a crew comes there, they're going to be like, well, these guys are going to try to get out of the transport. Well, these guys are going to argue with us. It just almost isn't worth it at that point.
And when you do have those instances, involve your MedCom. The other thing too is Gerd and I were talking about this a couple of months ago where he had a situation, again with 4210, where the POA did not want this patient transported, but the hospice nurse wanted the patient transported. And of course, this is at 2 o'clock in the morning, so are you willing, you and your crew, willing to remain on scene and have that extended discussion, which is probably going to turn into a 30 or 45-minute scene time in order to not transport the patient? And it all comes down to what, like we were talking earlier, advocating for your patient, what's best for them. You know, if they're on hospice, do they really need to go to the ER? Is that the best place for them at this time? So there's a lot of variables that come into it, but involve the MedCom, and then that's something that we need to hear about it on our end as well, so we can look at potentially addressing those issues or at least monitoring them for the future. So.
All right. So now moving on to something